Welcome to this presentation on pulmonary function testing measurements, or a better title would be a discussion on lung volumes. Hi, I'm David Zobek. I've worked in the ICU as a respiratory therapist. I also have done pulmonary function tests. I have my CPFT, RRT, and a doctorate of education. I hope you find this helpful in understanding the basic pulmonary function measurements. So this is a typical pulmonary function report. A lot of numbers, that scares a lot of people. So let's take a look at this first box, lung mechanics, and you can see there's actual and predicted measurements, pre-bronchodilator, and then the second group is post-bronchodilator, actual, percent predicted, and the change. We'll get into that later, but if you look down the line, you see FEVC, FEV1, FEV3, FEV to FVC, and all these other measurements. We'll talk about some of them. We'll focus on the key ones, which will help you better understand the pulmonary function tests. Now, in your disease class, you probably saw there's a ton of respiratory diseases of the lungs, but there is only two real categories of pulmonary diseases: obstructive and restrictive. Obstructive diseases, we use the flow rate measurements such as FEV1, peak flow, FEV to FVC, as indicators of how well that person is doing, and if those are abnormal, it gives us the indication that there can be an obstructive disease. Restrictive diseases reduce the lung volume. You'll have a smaller than normal breathing volumes. And so we look at the TLC, total lung capacity, RV, residual volume, and FVC, functional FVC, okay? Now, to further understand these two categories, obstructive lung diseases affect the airways. Restrictive lung diseases affect the alveoli, the thoracic cage, the respiratory muscles, etc. Now, to simplify that even more, we see that obstructive diseases have difficulty with exhaling the air, getting it out, whereas restrictive have difficulty getting it in. You can't breathe deep enough. With the obstructive diseases, we see there is an increase in the airway resistance. This is usually seen as difficulty in exhaling, as I said earlier. It's due to the narrowed airways or obstructive airways, as seen in COPD, asthma, cystic fibrosis, etc. Whereas the restrictive lung diseases have a decreased compliance, lung compliance, thoracic compliance, or compliance of both lung and thoracic. This results in a difficulty in fully expanding the chest, the lungs. This results in reduced breathing capacity, volumes, and that coincides with a reduced oxygenation. This can occur within the lungs themselves, such as within interstitial lung diseases or pulmonary fibrosis, which makes the lung tissue more difficult, harder to expand, or with problems with the chest wall, muscles, nerves that control breathing. So you have this limitation, you just can't get the air in but the tissue, the lung tissue itself, is okay. One other condition that kind of goes along with some of this interstitial problems is diffusion. Diffusion is the movement of gases through the lung tissue and into the blood. This problem can be seen in both obstructive and restrictive diseases. The key is reduced diffusion, reduced gas moving into the blood. This can be because of destroyed alveolar tissue, as in emphysema, or it can be caused by a loss of functioning alveolar area, tissue, such as in sarcoidosis. Now, before we ever do any type of measurement, we have to know what a normal value is for a given person. Fortunately, there's been a lot of studies done. There's nomograms and formulas which help determine what a normal value is for a man or a woman, the height, the age, all of those things create this normal value. And that's what we look at when we want to compare and see if somebody has some lung problems. So this is a comparison measure of the amount that the pulmonary function test shows against the predicted value, which came from those nomograms and formulas. This is used to determine the patient's condition, whether or not they have obstructive or restrictive problems or diffusion problems. It assesses the significance of abnormal measurements. Okay, so without something to benchmark against, without these normal values, the testing would be worthless. So we look at a normal person of the same age, sex, and height, and how well this patient that we just measured is doing. So when you look at a pulmonary function report, you're going to see a column that says percent predicted. That's an easier method of identifying the amount of dysfunction or the lack of dysfunction, depending on if the patient is normal or abnormal. So to get this percent predicted, it's simply dividing the measured value by the predicted value and multiplying that by 100. For instance, if we measure the patient's forced vital capacity to be 3 liters and the predicted was 4 liters, it would be 3 over 4 times 100, which gives us 75%. So this person, this measurement is 75% of normal. And what we'll find out later is usually anything under 80% is considered an abnormal condition. So as I said, we want to know if a person is abnormal in their measurement. Now, it doesn't have to be all of the measurement. It can be key measurements in flow or in volume. But if they are greater than 80%, then they are considered to have normal lung function. Now, if it drops below 80%, down to 65%, that level of severity would be called mild. So we want to identify the significance of that impairment. And then from 64% down to 50, that's a moderate impairment. And 49 to 35% is severe, and then less than 35% is very severe. So in these measurements, we not only identify if a patient normal or has some level of lung function impairment, as well as how serious that function, that impairment is. A pulmonary function test is simply a measure of how the patient is breathing. We have the patient breathe in different ways, and that way gives us the data we need. The most common is a big deep breath and then exhaling it all the way till you can't get anything out, and that gives us a vital capacity. Now, in the graph to the right, you can see of the various measurements that are obtained with your lung function. And I'm going to get into each of those as we go through some of the measurements. This information is typically taught in every respiratory program I know, and it's key to understanding lung functions. Right now, take a great big deep breath, as big a breath as you can, and hold it. The air in your lungs all the way down to past the point that you can exhale out, that's called the total lung capacity. It's the maximum amount of air in the lungs. Total lung capacity will be reduced in restrictive disorders. However, if it's a combination of obstructive and restrictive, that may not hold true. It is simply the amount of air in the lungs after a deep inspiration. Now, we can exhale everything out that will take us all the way down to residual volume. The residual volume is the amount of air that you cannot expel. We'll get into this a little later. As you are sitting there listening to this presentation on lung function, you are just passively breathing. That's called tidal volume. It's a passive resting breathing, and it is normal in both obstructive and restrictive conditions. Thus, since it's not affected by lung diseases, it tends not to be a good indicator of dysfunction. We only look at it as a measurement to help us identify other aspects of the lung function testing. A vital capacity is a deep breath with a complete exhalation. Now, if we have the patient force that exhalation out, we can get the forced vital capacity, and that gives us the flow rate measurements. A reduction in flow rates indicate obstructive conditions. Now, vital capacity can vary with age, height, and gender. As you are breathing and you come to the end of an exhalation just before you take another tidal breath, if you inhaled completely after that point of tidal exhalation, that would be called inspiratory capacity. This is usually reduced in both obstructive and restrictive conditions. However, restrictive lung diseases usually have much smaller volumes. It is a deep breath after passive exhalation. They said inspiratory capacity is reduced in both obstructive and restrictive conditions, but in moderate to severe obstructive problems, this can be due to an increase in the FRC, the functional residual capacity. So normally, the FRC helps hold the inspiratory capacity at the same normal level. But in the graph on the right, you can see that in blue, the functional residual capacity is much greater Thus, it's taking away volume that is usually used by in-story capacity. Now, incidentally, athletes and people who do wind musicians, wind instruments, have technically, usually, much larger in-story capacity. That's because they kind of have exercised their lungs and stretched them out and maximized their lung capacity, at least in the in-story capacity. In-story reserve volume is one of those measurements that we usually don't look at, we usually don't measure because it's not diagnostic. It's most often normal in both disease conditions. So if we do want to know what the in-story reserve volume is, we simply calculate it by taking the tidal volume from the in-story capacity. And if you look at the graph, you can see how the bottom of the in-story capacity is the same level as a passive tidal exhalation. Next measurement we're going to be talking about is ERV, extraordinary reserve volume. It's a calculated value, calculated by taking the in-story capacity away from the vital capacity to give us ERV. The ERV is the amount of air in the lungs after that passive tidal volume breath. The value of ERV is to determine residual volume by subtracting ERV from FRC gives us the residual volume. FRC, functional residual capacity, is a difficult volume to measure because it contains not only the exhaled air from the vital capacity, but it also contains the air that we cannot exhale no matter how hard we try. FRC cannot be measured directly, so we have to use other test methods. In pulmonary function testing, there are several methods that can be used to measure the FRC. Nitrogen washout is one, helium dilution is the other. Both of these are no longer or very frequently done because we have the body box, which will give us the thoracic gas volume, and it's a whole lot quicker and easier to do than the previous two methods. FRC is important to determine the TLC. As I noted earlier, TLC indicates if there is a restrictive problem. Once FRC is measured, we then can identify how much the residual volume is, simply by subtracting the ERV from the FRC. And that gives us the residual volume. Residual volume is that trapped air in the lungs. If it is increased, it can indicate obstructive problems. When we add the RV to the vital capacity, that can indicate if there are restrictive problems. So FRC plays a very important role in both identifying obstructive and restrictive problems. Normal residual volume is about 20% of the total lung capacity. So by looking at that, if we have a much larger RV, then we can identify obstructive conditions. FRC being larger is about 40% of the TLC. That enlarged RV FRC is important for us to identify the obstructive conditions. Now, that's not the only measurement, because we also have the flow measurements from the forced vital capacity. Those help us identify the severity of the obstructive condition. If, when we add the RV to the TL to vital capacity, then we get total lung capacity, and looking at that, if it's reduced, we know that there is a restrictive problem. RV and FRC are typically reduced proportionally, not one less than the other. If you don't have a TLC because an FRC was not done, then the only possible indication of restrictive problems is the forced vital capacity. A decrease in total lung capacity and FRC is seen in pulmonary fibrosis, atelectasis, consolidation. There's a whole list of other conditions that will reduce the lung volume. Now, the RV and FRC and TLC and the vital capacity as a forced maneuver are important measurements in the whole pulmonary function testing to identify if there's an obstructive condition or restrictive condition. Now, well, this concludes my presentation on pulmonary measurements, or actually a discussion of lung volume measurements. Hopefully that's been helpful. The next one in this series is on pulmonary interpretations, and that hopefully will give you some shortcuts on understanding all of the data that is given to you on the pulmonary function report. Thank you.